Hi, I'm Laura Davis. I'm a PhD student at McGill University, and today I'll be talking about using additive and relative hazards to quantify colorectal survival inequalities for patients with a severe psychiatric illness. So first, just quickly, the difference between relative and absolute effects. So relative effects are measured on the multiplicative scale and represent a ratio comparing two groups. They're often measured through relative risks and odds ratios. On the other hand, absolute effects are measured on the additive scale and represent the difference between two groups. These are measured using risk differences and number needed to treat. So in order to properly interpret the effect of a particular exposure on an outcome, it is important to report both relative and absolute effects. So the absolute effects give context to the relative effects. This is because absolute effects, such as risk differences, incorporate information about the prevalence of the outcome in the population, whereas relative measures such as odds ratios or risk ratios only provide information about the strength of the association. And when we use one measure over the other, it can actually lead to different results depending on which measure is used. So for example, if we're looking at the relative difference or the relative effect in a disparity, which might be stable over time, but if both groups are moving towards worse outcomes at a similar rate, we'll see that the absolute number of people affected could be increasing. So it's important to present both measures. Moreover, it's important to use both measures, particularly when we're looking at questions as they relate to health inequalities. This is because it's particularly important to be precise when we're looking at people who are part of vulnerable populations, because we don't want to misrepresent the conclusions, which could lead to increased disparity in already vulnerable groups. So by presenting both absolute and relative measures, we're providing the full picture for the effect. And then next, absolute measures provide better context and are more easily interpreted by decision makers. So despite these recommendations from the WHO and reporting guidelines, very few studies actually report absolute and relative effect measures. A systematic review by King and colleagues looked at 344 empirical studies on health equity in the top 10 medical journals, and they actually found that only 7% reported both measures and 75% reported only relative measures. In studies using time to event data, a systematic review found that 8.4% reported absolute effects, and 50% of those studies that did report absolute effects actually used inadequate methods. So providing absolute numbers, such as the number needed to treat, is much more common in randomized control trials and when the outcome is continuous in an observational study. And we know that it's actually less common when we're looking at observational research when the outcome is dichotomous or categorical. There could be a few reasons for this. It could be that there's a convention for reporting relative risks and odds ratios that doesn't yet exist for risk differences. And also that the methods for obtaining risk differences when using a categorical outcome are not quite as straightforward as when we're obtaining a relative risk. Moreover, when we're using time to event data, it can be even more complicated because we need to account for follow-up time and censoring. So we conducted this study to demonstrate the use and importance of both relative and absolute effects in a real-world example, examining colorectal survival for patients with and without severe psychiatric illness. So just to set the stage a bit, physical illness is the leading cause of death in people with mental illness, but cancer survival has received less attention. So severe mental illness might lead to worse cancer survival through symptoms of the mental illness itself, social vulnerability, health and lifestyle behaviors, as well as system factors. And these factors all interact to make it hard for people with severe psychiatric illness to access healthcare and can create contraindications with medications and a lack of patient-centered care and stigma for the patient. The current evidence that examines psychiatric illness and cancer survival suffers from the use of inappropriate controls, low study power, controlling for variables on the causal pathway, and combining multiple cancer sites. So we use data from the Ontario Administrative Health data from ICES in Ontario, Canada. Our cohort consisted of colorectal cancer patients diagnosed between 2007 and 2012. And our exposure was defined as severe psychiatric illness, as a diagnosis of major depression, bipolar disorder, schizophrenia, and other psychotic illnesses in the 6 months to 5 years before the cancer diagnosis. And then we further categorized it as inpatient, outpatient, or none. Our outcome was survival from the date of diagnosis, and we controlled for confounders of age, sex, tumor location, and rurality. So we measured relative effects using the Cox proportional hazards regression. This is on the multiplicative scale and handles censored data, produces a hazards ratio with a 95% confidence interval, and can be interpreted in this specific case as the relative hazard of death in those with an inpatient or outpatient psychiatric illness compared to those without. And it controls for the relative effect of confounders. We use SAS to test for this. And then to calculate the absolute effects, we used the ALIN's semi-parametric additive hazards regression model. This model handles time to event data, but does so on the additive scale. So we get an absolute difference with a 95% confidence interval, and this can be interpreted in this case as the absolute difference in the number of deaths among those with inpatient or outpatient psychiatric illness compared to those without per unit of time. And it controls for confounders on the additive scale. We use the R time rig package to come up with these estimates. So our final cohort consisted of about 24,000 colorectal patients. 1% had an inpatient psychiatric illness and 2% had an outpatient. Median follow-up time was 4 years. Patients with an inpatient or outpatient severe psychiatric illness were more likely to be younger, male, and diagnosed with unknown stage, as well as live in urban areas. And there were about 10,000 deaths in the cohort, and increasing deaths with increasing severity of psychiatric illness. So here you can see the relative effects. So patients with an outpatient severe psychiatric illness were at a 40% increased hazard of death compared to patients without, and then patients with an inpatient severe psychiatric illness had a 90% increased relative hazard of death. In terms of absolute effects using the ALIN model, patients with an outpatient SPI had 3 additional deaths per 100 person years compared to patients without, and patients with an inpatient severe psychiatric illness had 8 additional deaths per 100 person years compared to patients without. So overall, the interpretation of this, we can say that colorectal cancer patients with a severe psychiatric illness had an increased risk of death using both additive and multiplicative scales. And here, the risk difference represented an increasing number of deaths with increasing severe psychiatric illness, and the relative risk represented increased hazard of death with increasing psychiatric illness. And you can see that by talking about the number of deaths with the risk difference, we're able to provide some concrete numbers that policymakers can really understand when they're looking at these numbers. So overall, the ALIN model offers some advantages. First, it's relatively simple to use. It's very similar to running a Cox proportional hazards regression model. And it can be used with time varying and time fixed covariates, and can be used in the presence of competing risks. Other options do exist to convert absolute hazards to baseline hazards, but they are not available across all standard statistical software, nor are they commonly applied. So in conclusion, we recommend the use of both additive and Cox proportional hazards models to obtain absolute and relative measures when healthcare disparities in time to event outcomes are investigated in order to provide a more comprehensive risk picture that is useful for clinician and policy decision making. So I'd just like to thank our granting agencies, and thank you for your time today, for listening to my presentation, and I hope you enjoy the rest of the conference.